I'm Laurie Sen from BC Cancer in Vancouver, Canada, and today I'm here with my colleague, Dr. Judith Trotman. Dr. Trotman is a clinical and laboratory hematologist from the Concord Repatriation General Hospital and University of Sydney in Sydney, Australia. So thanks for traveling all this way to talk to me today. She's had a strong research interest in the area of indolent lymphomas and has significantly contributed to the literature and the management of patients with indolent lymphoma in terms of the development of novel therapies. She's also the chair of the Australasian Leukemia Lymphoma Group, and she is known to all of us as the founder of Women in Lymphoma. That's been a great organization that has been trying to promote research careers for females and women with lymphoma. So today we're going to be talking about Waldenstrom's macroglobulinemia. I know a topic that is very dear to you. And I want to focus and ask you what your thoughts are on the role of BTK inhibitors in the frontline setting for Waldenstrom's macroglobulinemia.
Well, thanks, Laurie, and it's lovely to be here. And it's fair to say that BTK inhibitors have transformed the lives of patients and physicians treating patients with Waldenstrom's macroglobulinemia. In the first-line therapy, I've actually started to shift and become quite keen on using zanubrutinib in particular, such a well-tolerated second-generation BTK inhibitor, and that is the one that I have access to in Australia, for those patients who are very frail and are going to be less tolerant even of the most gentle chemotherapy, dexamethasone, rituximab, and cyclophosphamide. And as the data bears out with longer and longer follow-up, with the zanubrutinib in the early phase 1-2 trial, I'm getting a sense that we've got, a median probably of at least 7 years survival. So that's my cutoff. If my patient otherwise has a 7-year survival probability or less than 7-year survival probability, I'm going to be selecting that well-tolerated BTK inhibitor to start, because it's, to be honest, the closest you can get to a set and forget treatment for Waldenstrom's macroglobulinemia. It also makes it so much easier to deliver. They very quickly can reduce the frequency of their follow-ups. We're not clogging up our day therapies with intravenous therapies. We don't have to worry about the rituximab flare, tolerance of rituximab. So for those who I really don't expect to have a long life expectancy, zanubrutinib is what I'm using.
Yeah, so I have to say, we don't have frontline BTK inhibitors funded universally in Canada. So our frontline therapy still relies on chemoimmunotherapy, which for the most part would be the combination of bendamustine and rituximab for 6 cycles in our patient. Although we've been lucky to have zanubrutinib available on compassionate access programs, so I have had the capacity to give it to a fair number of patients. But I have been pursuing it mainly for patients, as you say, who are on the frailer side, who are really not appropriate for chemoimmunotherapy, or patients who say, I don't want that chemoimmunotherapy. Is there anything else you have to offer? So that compassionate program actually has opened an option for us.
Yeah. I agree. Certainly my mantra in 2025 with Waldenstrom's is playing the long game. And so for the young patients in their 50s and 60s, rituximab and bendamustine is a fixed duration, well-tolerated therapy. But as the patient gets older, many of them will still have a very long life expectancy. If you take away their WM. And so for those, I do use dexamethasone, rituximab, and cyclophosphamide. But I would, bearing in mind that you do have zanubrutinib up your sleeve for the second line, I would have a lower threshold for stopping and pulling back if the patient is intolerant. And then you can take a pause because you have the zanubrutinib available in the second line therapy, as opposed to pre-BTK inhibitor era, where we'd really, have to try and push the patient through their chemoimmunotherapy.
Yeah, well, that leads me into the next question I was going to ask you, and that is, how have BTK inhibitors affected the management for the relapse refractory patient or the second line and beyond setting?
Well, we have good data that, it's very hard to get data on sequencing because the clinical trials just don't follow up the patients for long enough. But from our patient-derived data set, whimsical registry, we have good data that confirms that the longest time to next treatment, which I actually think is a more relevant endpoint for patients than progression-free survival, the time to next treatment is longer with patients who receive a BTK inhibitor compared to whether they receive bendamustine or rituximab or dexamethasone rituximab cyclophosphamide. So in a patient who's already had a chemoimmunotherapeutic regimen, zanubrutinib is definitely what I reach for more than 90% of the time. Occasionally in the young patient, because I am playing that very long game, if they've had a very many years response to their initial immunochemotherapy, I may counsel them and we decide together whether or not to go chemoimmunotherapy again and save the BTK inhibitor for the third line. But that's a minority of patients.
So I have to say that in Canada, we have had zanubrutinib funded for relapsed refractory patients, and it really has become the go-to therapy for patients that have not yet received it as soon as they need their next line of therapy. It's highly likely that soon we'll also have funding available for ibrutinib and rituximab, although I think many clinicians are really concerned about going back to ibrutinib now, the first generation BTK inhibitor, and particularly combined with rituximab, where most of us are more weary of the combination with the anti-CD20 as well. So I can't see a lot of uptake there. I think, based on the weight of the data, that zanubrutinib will likely be the preferred treatment moving forward in the relapsed refractory setting.
Absolutely. Ibrutinib was a game changer. First in class, but it's not best in class. And there is no doubt that patients achieve their very good partial response faster with the zanubrutinib than they do with ibrutinib in that phase 3 randomized clinical trial, the ASPEN. Zanubrutinib has the edge in those poorest patients who are mid-88 wild type, or the patients who have CXCR4 mutations. But that's actually not the main reason why I choose zanubrutinib first. It's the tolerance. All right. In ASPEN, 20% of patients had to stop ibrutinib because of side effects, versus only 9% of patients on zanubrutinib. Yes, you have that slightly higher rate of neutropenia, which is easily managed with judicious use of G-CSF, but overall, the GIT side effects, the bruising, the fatigue, the arthralgias are so much lower on zanubrutinib. So, I don't see a role for using ibrutinib even in combination with rituximab. And to that point of the rituximab, I'd rather save my rituximab to use it in combination with chemotherapy, or potentially, crystal ball gazing down the track. I do believe that rituximab synergizes very well with the BCL2 inhibitor in the management of Waldenstrom's. And that's where I'd like to save my rituximab, for either chemo or with the BCL2 inhibitor.
Yeah, so I would agree. I think the weight of the data suggests that zanubrutinib is a second generation agent, not only has better tolerability, but also more likely, maybe even better efficacy than ibrutinib, and would be the preferred agent, and certainly as a single agent, I find would be the more desirable approach. You did mention the MYD88 negative population, where we do have some data from the zanubrutinib trial in a separate arm where those patients actually had a fairly good response rate with it. And I have to say, as a personal anecdote, I've now treated 3 patients in my own clinic who are MYD88 negative, and they all responded and are continuing on therapy. So I think that it is certainly an option for those patients as well. Yes. So moving forward, what are you excited about in terms of the future for the options that might be forthcoming for the management of relapsed refractory Waldenstrom's?
So in the patient who has progressed after chemoimmunotherapy and progressed after a BTK inhibitor, there is actually a number of really promising agents. Obviously, if they're progressed after a covalent BTK inhibitor, then a non-covalent BTK inhibitor such as pirtobrutinib clearly shows very high response rates of approximately 70%. The problem is we don't know yet the duration of those responses. The trials are ongoing, looking at the role of both venetoclax, but also in particular sonrotoclax, the more potent and again well-tolerated BCL2 inhibitor in the management of patients with relapsed Waldenstrom's. I'm less interested in the data of the sort of combination with zanubrutinib. I think in such an indolent disease, I prefer to be using them sequentially rather than together, except for perhaps the very poor risk patient population. But what also makes me quite excited is the impact of the BTK direct protein degraders in clinical trials. At whatever dose has been trialed in the early phase 1 trial, we're seeing excellent response rates, over 90%, responses of meaning, clinical responses, and 75% of patients achieving a major response. So of course it's very early data, very early days, but I'm really interested to see how patients how sustained a response patients will have to these direct protein degraders, which are also very well tolerated.
Well, I think we're certainly excited about all these novel agents coming forward. I know as Canadian clinicians, we actually need to ramp up the clinical investigation here in Canada, because I think sometimes the clinical trials are more focused on the more common indolent lymphoma patients that we see. So we certainly have a goal of increasing the number of clinical trials available here to get access to these agents sooner. But I have a feeling this conversation will continue because more data will be forthcoming, and I look forward to talking again when certainly the field will undoubtedly be changing even more. So thanks for joining me today.
My pleasure.